My name is Kristina Hni, and I'm a final year PhD student, and I'm presenting a presentation called Evaluating a Pilot Intervention Development Program Utilizing Respiratory Monitoring to Prevent Drug-Related Deaths. That was a mouthful. So I just want to begin by expressing my deepest gratitude to the people who participated in the study, because without them the study would not have been possible. And I just have a couple of disclosures. So Pneumowave Limited donated the study equipment. However, the study is investigator-initiated and the company had no control over the data. I'm funded by an MRC IK studentship, and my colleague Andrew Radley is in a receipt of a couple of research grants, and the remaining offers to declare no conflicts of interest. So just beginning, so Scotland has the highest drug-related death rate per capita out of any European country, and approximately 3.5 times that of England and Wales. And the majority of drug-related deaths there are caused by opioid-induced respiratory depression. So the place where this was conducted was Dundee City, and Dundee City has the second highest standardized drug misuse death rate of any of all local authority areas. And in 2021, 68% of drug-related deaths in Teesside, which is the region of Dundee, occurred when people were using substances alone. And that is important because nobody was there to be able to give them naloxone. So this is the device that was used in the study. So this is the Pneumowave biosensor, the Pneumowave Alert. The sensor is very small. It's about the size of a bottle cap and attaches just below the collarbone. And it works similar to a Fitbit in that it has an accelerometer and it measures how the chest rises and falls. So in our study, the biosensor passively collected respiratory data and data transferred to the hub via Bluetooth, which is then stored on an SD card. And it was uploaded via secure Wi-Fi, and then it was deleted from the hub. And the data was only linked to serial numbers. No patient identification was used. So this is the study recruitment. So 70 participants were recruited. 30 of them were lost to follow-up, 4 formally withdrew. 36 completed the full study with an additional 12 of the ones that did not complete, they completed at least 1 week of study data. And we unfortunately had to discard 5 participants' data because it got corrupted in storage. So this is the respiratory data. So collectively, the 43 participants whose data we used, they returned with 5,760 hours of recorded respiratory data, of which 2,365 hours were respiratory data. Participants returned with an average of 134 recorded hours of data per participant, of which an average of 55 hours were respiratory data. Participants returned with an average coverage of time of the study being 20%, of which 8% was respiratory data. And the average respiratory rate was 10.74 breaths per minute, which is actually moderate respiratory depression. So just to show you what the data looked like, because it was reviewed manually, on the left you can see data from a participant who, while he did use heroin, he did not have a respiratory disorder. So that's 12 breaths a minute, which is considered normal. While on the right you can see an apneic episode of 35 seconds, which came from a participant who used both heroin and benzodiazepine simultaneously. So just reviewing the apneic episodes, so we focused on apneic episodes which were, if there were free 30 seconds episodes in an hour, so we would focus on those episodes. Participants came back with 851 of such episodes. 374 of them were artifactual data. 82 of them were occurring during movement. 371 occurred during respiratory depression. 20 occurred during normal respiration, and 6 occurred during bites respiration, which is a respiratory pattern where you have several breaths followed by apnea, followed by several breaths. And 93% of the apneic episodes occurred during respiratory depression, 5 of them during normal respiration, and 2% during bites respiration. So now I'm going to move over the qualitative study, which we conducted to see if the device was acceptable for the people on the study. So we carried out semi-structured interviews with 21 participants. 20 of them were participants who had completed the full study, which was 4 weeks. And one of them was a participant who did not complete the study, but we wanted to know their perspectives to see why they were not able to complete the study. And we conducted focus groups with eight groups, which were members of the Scottish Ambulance Service, harm reduction workers, Dundee non-fatal overdose group, and harm reduction nurses, and support group members and staff. We used thematic analysis to analyze the interviews. So in the participant interviews, the themes were identity and experience of substance use, intervention, receptiveness and incentivization, and emergency response and responsibility. On stakeholder focus groups, we had barriers between people who use drugs and services, intervention, integration into existing services, and emergency response pathway. And we interpreted these findings using COM-B and NPT. COM-B is the capability, opportunity, and motivation leading to behavior model as part of the larger behavior change wheel. And as an example of capability, it was for the participants to be able to attach the device to their body, and the ability to rotate sides for device attachment. The motivation, for example, was witnessing an overdose or drug-related death. And also a big thing that we found out was the therapeutic relationship that they had with the staff at the needle exchange where the study was conducted. So if they had a very good relationship with the needle exchange staff, they were very willing to participate, which we found interesting. And the opportunity factors was, for example, housing, security, access to services, access to electricity, and also income, as well as the relationship with friends and family. So this was the normalization process theory. So this is how we could put this, how we can make this put into practice. So the capability, the coherence was that the focus group participant understood the intervention. They spoke about comparable interventions such as safe consumption rooms and virtual spotting phone line in Glasgow. And they also spoke about assertive outreach and stressed the importance of immediacy. The cognitive participation was, again, same that we found in the interviews, was that a death of a family, a friend or a family member was identified as a motivating factor for participation. But it was also acknowledged that some participants may not be ready for an intervention of this type because the intervention is not a cure-all. In terms of the collective action, incentivization, such as transport and electricity, were identified as a barrier. There was an issue of responder consent and mental health. For example, if the device would alert several times a night, that would be very difficult for example, our parents to be responding to. It was found out that nurses and overdose prevention workers would need to be trained, and that the device may not be a priority for areas with low funding. And it was also acknowledged that the intervention needs to be integrated into existing interventions, such as assertive outreach, which is an intervention where people who have recently overdosed are then contacted by harm reduction workers to give them support. And finally, the reflexive monitoring was that the main outcome was lowering overdose fatalities, but the secondary outcome was that it could improve engagement with substance use services, and it would engage participants in their own health care. So finally, we did a Delphi study to see what the correct limit would be for an overdose response. So we did 2 rounds. So there were 49 responses in round 1 and 42 responses with round 2. So the results of round 1 were that 73% agreed that a single continuous central apneic episodes of over 30 seconds is an appropriate duration for an alarm in the proposed device. An average of 76% agreed that there should be a step from a personal alert to third-party alert to an ambulance response. 79% of responders agree that there should be 3 or 5 audible prompts, which we then refined in the next round. That 83% agreed that 3 audible prompts should sound prior to an alert. 83% disagreed or were neutral, that service users should be allowed to adjust the timings of the device themselves. And 73% agreed to strongly agreed that an audible prompt would motivate bystanders to intervene. So as part of the study, we conducted 2 PPI groups, so that's patient and public involvement. We conducted 2 PPI groups, one in Dundee in the needle exchange where the study was conducted, and another one in Kirkcaldy, which is in Fife, which is east of Dundee. And generally, the opinions of the attendees match the opinions of the experts that were invited to respond. So these are the conclusions and future study aims. So the data suggests that the device successfully captured respiratory anomalies. Experience with overdose or drug-related death was a motivation factor to device wear, and the Delphi process suggests that 20 to 30 seconds is a good point to intervene. And in the future, this study will be conducted in a second part of the study is planned to be conducted in hostels, where it will be used with a mobile phone instead of the device that had to be plugged into the wall, which was a big limitation of the study. Because the data could only be captured when the person was in the same room as the device, because it was captured through Bluetooth, so that will eliminate this factor. So that is me finished. Thank you very much. If you have any questions, throw them at me.